Good day, my name is Ole Christiansen. I'm a professor at Aalborg University Hospital, and I thank the organizers for having invited me to give this presentation about the recurrent pregnancy laws guideline produced by the European Society of Human Reproduction and Embryology, ESHRE. I have nothing to disclose. The Guideline Development Group started its work in 2013, and originally it comprised the persons listed in the upper part of this list. And later, when the guideline was updated in 2021-22, some new members listed below were added. Each member focused on a specific area of recurrent pregnancy loss. I took care of the topics of RPL and immunology and unexplained RPL. However, the final guideline was approved by all members and also by the ESHRE Executive Committee. It's a huge work to perform such a comprehensive guideline. The work started in 2013, and after a lot of meetings in the guideline group, the first version was published in 2017, and after further virtual meetings in the group, the updated guideline was published in January of 2023. For me, the most controversial statement in the guideline was that RPL was now defined as only 2, not necessarily consecutive pregnancy losses. I was very much against this definition because it will include a lot of women who had 2 pregnancy losses just by chance due to embryonal aneuploidy, including such women in the guideline is not good. I think we should concentrate our limited resources on patients with a higher number of pregnancy losses, and including such women with a good prognosis in clinical trials, such as case control trials, will clearly dilute the associations between risk factors and RPL, and including such women in treatment trials will clearly dilute the effect of the treatment being tested. However, the majority of the guideline group voted for this new definition. However, the definition is not approved by several specialist societies such as the Royal College and the German Society for Obstetrics Gynecology. A good aspect of the new guideline was that biochemical pregnancy losses, so-called non-visualized pregnancy losses, were now included in the definition. The updated guideline comprises 177 pages with 77 recommendations, and I have no time to go into all these recommendations, but have to concentrate on the most controversial recommendations and significant changes in the updated guideline. When the first guideline was published in 2017, my impression was that many researchers and clinicians thought it was very conservative because it rejected a lot of investigations and treatments already implemented in clinics and laboratories. Here is listed some of these investigations deemed to be useless in the guideline. Routine genetic testing of aborted tissue should not be undertaken. You should not do parental karyotyping. You should not test for hereditary thrombophilia. You should not test for NK cells, cytokines, HLA polymorphisms, and you should not routinely test for PCOS, androgens, prolactin, ovarian reserve, or luteal phase defects. The reasons for these non-recommendations were that too few and small relevant studies existed, the results of the studies were divergent, and if you had an investigational risk factor that had proven validity, no proven therapy existed for the risk factor. In the new updated guideline, some new recommendations were included. Now it's recommended to evaluate the woman's prognosis based on both age, number of previous pregnancy losses, live birth, and now also their sequence. This change was based on a large population-based study by Colte et al., finding that the sequence of the pregnancy events were very important for future outcome. It was now also recommended that you could consider testing for antinuclear antibodies, and you should also consider a 2D ultrasound scan to rule out adenomyosis. And in recent years, there have been increased focus on the male contribution to RPL, so therefore now also it's recommended to assess lifestyle factors in the partner, and you could also consider assessing sperm DNA fragmentation in the male partners. In an ever-changing world, it's important to emphasize that some investigations were still recommended in the updated recurrent pregnancy guideline. Is still recommended to screen for lupus anticoagulants and anticardiolipin antibodies after 2 pregnancy losses. You can still consider to screen for beta-2 glycoprotein 1 antibodies after 2 losses. You should still screen for thyroid stimulating hormone and thyroid peroxidase antibodies in RPL women. And if the findings are abnormal, you should screen for other thyroid gland factors. And you should still make an assessment of the uterine anatomy, preferable by 3D ultrasound scan in these women. When the first guideline was published in 2017, many were shocked to see all the negative recommendations concerning treatments of RPL. It was recommended not to use progesterone treatment or HCG treatment, not to treat with metformin. It was recommended not to use PDTA or PDT-SR. It was recommended not to use anticoagulation treatment except in antiphospholipid antibody syndrome. It was recommended not to do surgery on the uterus. Immunotherapy was not recommended. It was recommended not to do endometrial scratching or use antioxidants in the male partners. And the reason for all these non-recommendations were, again, that too few and too small relevant studies were published and the results were too divergent. Due to publication of some high-quality multicenter randomized control studies, some new recommendations were included in the updated ESHRE guidelines about treatments. 2 multicenter randomized controlled trials have been published testing the use of levothyroxine to women with TPO antibodies who were euthyroids. And none of these studies found that levothyroxine increased the live birth rate. So therefore, this treatment is not longer recommended to euthyroid women with TPO antibodies or subclinical hypothyroidism. A large, high-quality Japanese randomized control study tested the use of high doses of intravenous immunoglobulin to women with 4 or more pregnancy losses when treatment was started in very early pregnancy, and it found that the live birth rate was significantly increased after this treatment. So this treatment can be considered for women with 4 or more pregnancy losses. Combining results of two multicenter randomized control studies in the UK showed that treatment with vaginal progesterone weakly but significantly increased the live birth rate in women with recurrent pregnancy loss, 3 or more losses, and vaginal bleeding in the pregnancy. So this treatment can also be recommended to these women. And lastly, a couple of studies showed that a special variant of ESHRE called PIXI, where sperm are selected by special methods, can decrease the risk of pregnancy loss in infertile women. It's still not documented that this treatment is also beneficial in RPL women, but it should be tested in the future. In the updated guideline, some treatment recommendations were maintained from previous time. Still, women with antiphospholipid syndrome and a history of 3 or more pregnancy losses should be treated with low-dose aspirin from before conception, and they should be treated with heparin in prophylactic doses from the day of a positive pregnancy test. Also, women with overt hypothyroidism should be treated with levothyroxine from before conception or during early gestation. For researchers, the most interesting parts of the updated recurrent pregnancy guideline is the sections about which research areas should be prioritized in the future in recurrent pregnancy loss. And concerning the definition of RPL, which is controversial, studies should be performed assessing whether associations of risk factors or effects of treatments changes will change definition, whether effect of treatments are stronger in women with 2 pregnancy losses compared with women with 3 or more, as an example. Also, in the area of organization of care, it's important to develop better models that are better than previous models can predict the chance of live birth in an individual couple with RPL. And such new models should include sequence of pregnancy events and also some validated biomarkers. It's also important to develop online tools for support to couples with RPL and staff. In the area of genetics, there is a need for more research in several areas. It's important to clarify whether performing PTTA in couples with RPL will enhance their prognosis, and it's important to clarify whether genetic analysis of pregnancy loss tissue provide information that can improve the pregnancy prognosis for the couple in the next pregnancy, and it's important to do cost-effectiveness analysis of parental karyotyping. In the area of thrombophilia, there's a lot of important research areas that should be explored. I here highlight the two most important areas that should undergo research. Randomized controlled trials should study the effectiveness of heparin treatment compared with placebo or no treatment in patients with antiphospholipid antibodies. No such really placebo-controlled trial have been performed. In these patients, it's also important to evaluate the effect of hydroxychloroquine to patients with RPL with and without antiphospholipid antibodies in randomized control studies. In the area of immunology, I think the most important research areas are performing a randomized controlled trial of use of moderate dosages of prednisolone in recurrent pregnancy loss. And it's also important to do studies, prospective studies, or randomized controlled studies of the effect of immunotherapy in women with RPL with or without selected immunological biomarkers that could be specific HLA class II alleles. Concerning the area of metabolic factors in RPL, I think that there's no need to do more studies of levothyroxine to women with subclinical hypothyroidism or TPO antibodies, because two large high-quality studies have clearly shown no effect of levothyroxine in these women. In the area of uterine malformations and recurrent pregnancy loss, almost no randomized studies have been undertaken. Only one randomized study have been published. It was of poor quality, but it showed no effect of removing uterine septum by hysteroscopy. I think in the future, uterine surgery in RPL women should only be undertaken in the context of randomized controlled trials. There have been increasing focus on male factors in recurrent pregnancy loss in recent years, and there's a lot of important research areas in this area. I think the most important is prospective studies studying the impact of male lifestyle alterations with outcomes both of sperm DNA damage per se and also of pregnancy outcome after RPL. And I think it's also important in randomized controlled trials to study the effect of combinations of antioxidant and vitamin therapy for men on the protection against sperm DNA fragmentation and also with regard to pregnancy outcome after RPL. I think it's also important to do randomized controlled studies of the use of PIXI as a treatment to improve pregnancy outcome in women with RPL and where the husband has increased sperm DNA fragmentation. And finally, in the area of female factors in RPL, I think there's a strong need for prospective study of the effect of preconceptual weight loss on live birth rate in these women. And there's also a strong need to do prospective studies of the role of chronic endometritis in women with RPL. And there's also a strong need to do randomized controlled trials of antibiotic therapy to women with this diagnosis. And finally, I thank the ESHRE for the huge support for producing this guideline and for the good collaboration between all the members of the guideline development groups in all these years the work have been performed. Thank you for listening. Thank you.